First of all, thank you very much to IMA Nashik and to the ISHBT for this kind invitation to speak on a topic which I was a little taken aback initially because it was on pregnancy, so I was wondering. Then I realized that there are two others who have spoken before me. And thank you very much for the kind introduction. And thank you, chairpersons, for being there for me for this meeting. Um, in terms of disclosure, I have nothing to disclose for this lecture, other than the fact that the roads from Mumbai to Nasik was not very good, but I had a fantastic driver who brought me well in time. So I'm hoping, like he led me here, I'll lead you through thrombocytopenia in pregnancy. It's a maze. It's a maze, thrombocytopenia in pregnancy. Let's see if we can make some sense. So you can have spurious. That means it's a wrong report. Collection is a problem. Platelets are stuck to each other. That's why the report has come wrong. One quick slide review under the microscope, and you're done. Then comes the commonest one, gestational. ITP, immune thrombocytopenia. Then there's a macroplatelet. If you get people coming from northeast, we have larger platelets, so they are thrombocytopenia, but they don't bleed. In fact, that is normal for them. And the whole life they have been low platelets, you don't have to worry about it. Then comes lupus anticoagulant, autoimmune disorders. Then comes preeclampsia, eclampsia. Now comes the difficult part. Then we have this microangiopathy, which is dangerous. Then comes DIC, which the acronym is death is coming. Infected causes can also cause thrombocytopenia, but not in the ambit of discussion today. Infections are known to cause thrombocytopenia, and the infective focus has to be diagnosed and treated. The learning object is to find out the common clinical signs and symptoms of thrombocytopenia in pregnancy. Let's understand the pathophysiology, diagnostic approach, and we'll look at a few. We won't look at all, we'll just look at a few. If you have a paper and pen in front of you, I want you to answer this question on your own letter pad, and we'll see at the end what comes up. What is the commonest reason for thrombocytopenia in pregnancy? You got 5 in front of you. I'm giving you 5 seconds. I'll go to question 2. Hypertensive disorders of pregnancy are common in which trimester?
Third, second and third. Third trimester.
Which is the thrombocytopenia associated with thrombotic coagulopathy? Which is the thrombocytopenia associated with the bleeding tendency? See how platelets behave? They can be quantitative problem, qualitative problem. Dr. Shahnaz has told us so beautifully. How is DIC suspected? So let's view thrombocytopenia in pregnancy. You have to have an automated CBC. You can't do without that. You have to look at everything. Hemoglobin, white cells, platelets, differential count, and the indices. Based on all this, you decide it's an isolated thrombocytopenia. Then only we'll be talking of thrombocytopenia. If there's something else, we will not call it thrombocytopenia. Then in that case, it can be either gestational or it can be immune thrombocytopenia. You are kind of sorted most of the times. But anemia is rampant in our country. And in pregnancy, it is 60 to 65% of our patients. So look at the hemoglobin indices, look for regular stuff such as iron deficiency, vitamin deficiency, thalassemia. Look for all those things. Not that they are causing thrombocytopenia, but don't miss them out because they are also important in pregnancy. Don't focus only on platelets. Ask your pathologist to look at the smear. If you got a hematopathologist, nothing like it. Look for broken cells, that is schistocytes. Look for abnormal cells in the WBCs. Maybe the hemoglobin platelets are for a reason which is malignant. And you might think of gestational thrombocytopenia, ITP and all. And also look for coagulation profile, which we just discussed. It's a possibility that the patient may have an underlying bleeding tendency. So there are checkpoints. Platelets less than 150, you've already heard. That is when we call it as thrombocytopenia. Its prevalence at the end of pregnancy is 6 to 11%. So it's not going to be too common in practice. But when it comes, you're scared. Because then, since it is rather uncommon, you have not an approach or an idea how to handle with it. As soon as the platelet starts going below 100,000, we are worried. But for you, fortunately, it's 1% of pregnant patients. But in our country, 1% of pregnant patients is a large number. So anyone's obstetric and gynecology practice, they will face thrombocytopenia in their patient. So our task in such a situation is to go through this maze, find out what is the pathophysiology, and we have to do a risk assessment. Because not only we have to know what is happening to the mother, but we have to take care of the child if and when the child is going to be born. And this thrombocytopenia is a dynamic feature. Throughout pregnancy, it will keep changing. So just because one platelet count is fine, that doesn't mean you don't do it in the pregnancy. You have to keep a watch on it and look at the trend, because sometimes the trend can tell you lots of things, and I'm going to show you how. Remember, the diagnostic distinction between the potential etiologies for thrombocytopenia is essential for having a correct treatment. If you think gestational and don't do about it, then you'll end up with another problem and you'll wonder, why didn't I think of the other issues there? 70% of the times, you're not going to have any major pathology. It's going to be gestational thrombocytopenia. Only if the platelet count is less than 100, please do investigations or then refer it to a hematologist. Bleeding with 50,000 and above, unlikely to bleed. Even about from 50,000 to 30,000, unlikely to bleed. It's below 10,000 that spontaneous bleeding can take place. And certainly when it's going below 100,000, you must start gearing up the patient to go to your friendly neighborhood hematologist. Basic thing in thrombocytopenia is what? Either you're not producing, you're consuming, or you're distributing the cells within the system. So there could be a splenomegaly, hypersplenism, there could be infection it's consuming, or the marrow is suppressed by whatever reason and you're not making enough platelets, so there is destruction, especially in the spleen. And we've got definitions. Mild is when it is above 50,000, moderate is when it becomes between 10 and 50,000, and severe is when it is less than 10,000. Why do you want to know it? Two things. One is, for trials, it is necessary to know where you are. And in regular real-world practice, you want to know what is the risk of bleeding and whether you should intervene with tests or referrals. Keep in mind, infection versus non-infection, that's a simple history that anyone can take and find out what's happening over there. And you can do the relevant tests. The current flavor of the month is dengue and malaria and typhoid, and all those things should be done to see whether they are contributing to thrombocytopenia. Usually someone sees a smear for pseudothrombocytopenia. We all hematologists have the advantage of seeing our slides, and we do look for pseudothrombocytopenia. And always we think of something more which is common rather than esoteric. Patients don't want fantastic diagnosis. They just want to know, problem hai ya nahi hai. That's what they want to know. So we have to sort their mindset also. So in that case, we take a medical history. We ask for previous history of thrombocytopenia. Did they have thrombocytopenia in the previous pregnancy? What was given to her in the previous pregnancy? Did she respond to steroids, immunoglobulin? Did she need anything at all? Did she turn out later on between the two pregnancies to have SLE, autoimmune diseases? Does she have a lymphadenopathy, organomegaly? That augurs poorly. That means there is some malignancy, you're missing out on something. So you have to be careful, discuss with them about continuation of pregnancy. Check the blood pressure. If there's a hypertensive disorders of pregnancy are known to cause thrombocytopenia. And peripheral smear. Big advantage we hematologists have. We look at the peripheral smear. We get a lot of information from that. So peripheral smear for us is like a mirror to the bone marrow. It gives us a lot of information. Let's look at quickly some of the common ones. Gestational thrombocytopenia. Usually it's benign. It is incidental. You just pick it up, and it's the most commonest cause of thrombocytopenia. It's a diagnosis many times of exclusion. So you need to do other tests to see this is only isolated gestational thrombocytopenia. It usually occurs in the second, third trimester, not in the first trimester. It goes rarely below 70,000. You just have to observe. Cesarean section is as per obstetric reasons. And if it's 80,000 and above, epidural anesthesia for LSCS is fine. Usually the fetus is unaffected, but this platelet count can drop in the next pregnancy again. So knowing the previous pregnancy, what had happened, is important so that you don't do unnecessary tests in the next pregnancy. You know that she was gestational thrombocytopenia. So that documentation should be kept as long as the patient follows up with you. Immune thrombocytopenia is the second most common one, 3 to 5%. In terms of asymptomatic behavior, but sometimes it can be symptomatic, especially if they're already ITPs, SLEs, they already have a low platelets and have become pregnant by whatever reason, accidental or by design, and then they come to you with platelet count of 20, 30,000 in the first trimester. Then the problem starts. They can have a higher risk of bleeding. Usually the platelets are low in the early part of pregnancy itself because many times they're already known. But sometimes pregnancy itself induces thrombocytopenia of immune nature because we know that pregnancy opens up hitherto unknown antigens from their various surfaces in the uterine circulation and then allows antibodies to form. Now, as the pregnancy progresses, this thrombocytopenia worsens, sometimes just remains standard. That's medicine for you. There is no formula, no mathematics. Just keeping a watch on them is the correct thing to do. And the degree of drop of platelets depends upon how much is her antibody being active in order to chew off her platelets. So sometimes the antibody production is at a low level, so platelets remain stable. Sometimes it's active. God only knows why. It's called GOK phenomenon. God only knows. And the platelets start coming down. Remember, these people who have got SLE or autoimmune thrombocytopenia, you must do their APLA study. You must do lupus anticoagulant, anticardiolipin antibody, and beta-2 glycoprotein. You must do these three. Because if they are positive, then this thrombocytopenia not only is part of that APLA, but miscarriages are known to occur. So you want to give these patients aspirin and low molecular weight heparin if the numbers are good to see that the pregnancy goes to term. In ITP, we don't know what the cutoff is. Most likely, most of the articles and guidelines and trials say 30,000. If it goes lesser than that, maybe immunoglobulin steroids. I read a fantastic article, 500 patients, of which half of them were given immunoglobulin and steroids. Some were given only steroids and some were just observed. And what did we come to know from that? If you combine the two, immunoglobulin and steroids, the number of days taken to bring up the platelets is much faster. But immunoglobulin is expensive. Everyone can't afford it. Steroids alone takes a little longer time and it has a lot of problems for the mother, sugar going up, blood pressure going up, hypertensive disorders of pregnancy. And in the fetus will be large. So cesarean section is going to be happening. And the fetus can develop diabetes in the future. A lot of counseling has to be done for the patient before starting on steroids. In this immune setup, fetus can also have low platelets. And as is the norm, you can go ahead with vaginal delivery if it is 50,000 and above. You may not be able to do a cesarean section, you can do a GA. Now most of the time, the anesthetists and obstetricians will not want a GA because then you're worried about the fetus also. But if you can't do an LSC, can't do an epidural, you can do under GA. And if it's lesser than 50,000, then you can try using one of these products, immunoglobulin, steroids. Don't forget, platelets will not work. Platelet transfusion, the platelets will be destroyed as fast as what her own platelets are being destroyed. So giving platelets is just of no use. Maybe if there's bleeding, you'll have to give platelets. Otherwise, it will be an act of omission. You have to give platelets at that point of time. And the rest remains the same. If the count is below 20,000 or bleeding, give immunoglobulin steroids if they can afford it. Then comes the problem features. 20% is the hypertensive disorders of pregnancy, which can cause thrombocytopenia. And the front runner for that is preeclampsia. But we can diagnose preeclampsia. So the obstetricians on follow-up will see the blood pressure. And many times the blood pressure is taken by a senior nurse because obviously the doctor can't take everyone's blood pressure in a busy OPD. But if a senior nurse has taken it, then a rising blood pressure, 140 to 160, and a diastolic which is 90, and there is now proteinuria of 300 milligrams in a 24-hour sample after 20 weeks of gestation, you are heading for a hypertensive disorder of pregnancy, especially preeclampsia. And if you don't stem it at that time, it's going to go to something worse, and we'll see that spectrum. So thrombocytopenia may be the first manifestation of this preeclampsia. BP may be normal, but the platelets are dropping. You'll notice it was normal, and now it's dropping. So Antony has to go up saying awareness is needed. We have to now control the blood pressure immediately and start monitoring the CBC even earlier. Onset is usually second to third trimester. It may occur in postpartum also. And usually, if everything goes well, by about day 5, 6, the platelets start rising again. The fetus can also have low platelets. We may have to give immunoglobulin to the fetus like in the ITP situation. Very easy to take care of hypertensive disorders in terms of diagnosis. Just do these 4 tests. Most of the time, you'll be able to answer it. So a blood pressure, a urine sample, and these 4 tests, you'll come to know which hypertensive disorder you're going to go with. So it's not a big deal, and it's not too expensive to do this. But if it goes on to HELP syndrome, which is hemolysis with low platelets and elevated liver enzymes, then we're heading for trouble. And there are criteria for it. Because with this, mortality and morbidity and mortality starts rising. And you're worried in pregnancy to have any kind of morbidity, mortality, because then it goes up for a questioning and there is an inquest which goes on. But once they develop hypertensive disorder pregnancy, one thing is very clear, and the patient is counseled. Chance of going for an LSCS is much higher than a normal pregnancy. And even in that, there can be high mortality. How do you pick it up? Is there a way to pick it up? There might be a way. An increasing concentration of active 1 Willebrand's factor, which Dr. Shahnaz has just beautifully explained to us, and dropping of the ADAM-TS13. If this happens, then we know that the patient is going from PE to something else. It may be from preeclampsia to eclampsia or HELP syndrome or something more. So you can do this test if you have the facilities and the patient can afford the test. Otherwise, you're going to land up with all these features into something called as severe preeclampsia. And you might even lose the patient at that point of time. Now, at this point of time, if there is preeclampsia or HELP syndrome, what do you do in this situation? So see the weeks of gestation. If the gestation is more than 34, there's no question, you deliver. There is no questions asked by anybody. We just say deliver. What if it's less than 34? We try to stabilize. And we try to bring the patient clinical status better. Now, steroids has been recommended. It makes no difference. So what do you mean by in 48 hours stabilize? Stabilize what? Stabilize the blood pressure, do the coagulation parameters, look for any other events that are taking place in the patient, look at the coagulation issues that are there, especially fibrinogen. If it's going below 200, ppH is high. So keep ready your supportive care. Tell your blood bank that we are going to need possibly blood components, and then suppose we can't take up, and the patient's relative says, no, we want to continue for 1 or 2 weeks more, you can do a therapeutic plasma exchange if the blood pressure is fine, but usually this doesn't happen. LACS is the commonest mode of delivery. Now, these are called hypertensive disorder of pregnancy, but as a hematopathologist, we look at it as microangiopathy or thrombotic microangiopathy, TMA. And there are 3 things that we have to be worried about. Let's just see clinically how to differentiate between them. So in a HELP syndrome, liver enzymes will be high. No doubt about that. Elevated liver enzymes. Part of the HELP syndrome, elevated liver enzymes. In TTP, the CNS will be altered. Most of the time, then the creatinine will be up. And in HUS usually happens postpartum, and the creatinine is really high. So there is a clinical way of going through this, to the method of madness in order to find out what we are doing. Because all 3 will have low platelets, they'll have schistocytes on the smear or fragmented red cells, and they may have a coagulation profile which will be altered. Now, acute fatty liver of pregnancy is one of the difficult ones. Hypoglycemia, if a patient is hypoglycemic and the coagulopathy is severe, liver is gone, then you know that you're heading towards AFLP. Now, in such a situation, you have to deliver, prompt deliver. Just give component therapy and get on with it. Some of the other component therapy we can use is factor 7. There is a recombinant factor 7A available. One shot of it, expensive, one shot of it, and we can make a difference to the patient. It can bring the coagulation to some form of control till you deliver, and then things might get better. Now, there is something called as LCHAD, the full form is here, which is in the fetus, which is affecting the mother, making the mother go to acute fatty liver of pregnancy. Otherwise, it's not common. Why do we need to know this? Because it's a pathophysiology. And in the next pregnancy, were she to survive this and go ahead, in the next pregnancy, we might have the same issue. So we can actually do a test of this and find out whether this is going to create a problem in the next pregnancy. TTP, the best test for it is ADAM-TS13. Now we have developed, we have got in our hospital ADAM-TS13 antibody, which is done. We don't do the activity, it is done by ICMR. But the kits are not available. So they do it in batches which takes a week. By the time the patient is either home or dead. One of the two. Because TTP is a dramatic disorder. You have to take decisions that second. You have to do it immediately. Once you see schistocytes on the peripheral smear, patient is obtunded, creatinine is rising, liver functions are rising, need of dialysis, ventilation is there, urine output is dropping, you know there's thrombosis going on all over. You need to do plasmapheresis. So first hit and then say sorry. Start the plasmapheresis. And then you can explain to the patients and family members and all that this is the way. It's that urgent that you have to do. These are the cells that you see. I don't know if you can see my arrow. Yeah. So these are the schistocytes which are seen on the peripheral smear in these patients. That augurs poorly for the patient. A fall in ADAM-TS13 and a rise in von Willebrand's factor normally occurs in pregnancy. So what is happening here is that as the ADAM-TS13 is dropping in normal pregnancy, if it drops below 10%, your TTP comes up. So it all depends upon how much ADAM-TS13 and von Willebrand the patient had to begin with. We assume everyone is normal. But then the rate of drop decides why some get TTP and some don't get it. So we are understanding these disorders on a pathophysiological level much better. But if you don't attend to all this and the platelets continue to go low and the patient now is getting more and more difficult, then what's happening now is you're getting a combination of inflammation, coagulopathy, you're getting an endothelial dysfunction, you're getting ischemia, the organs are starting getting, because there's thrombosis, thrombotic micro. And then there is organ failure. This leads to death. Now this is called DIC. Death is coming, or disseminated intravascular coagulation. You know, we could have picked it up early. The digits show changes, gangrenous changes. That is the first phase of DIC. Most of the time we miss it because by the time they come to us, they're in the second phase or third phase, which is clinical bleeding. That means because of the microthrombi, the coagulation factors have already been utilized, and now there is a decrease in the level of coagulation factors, which is why the patient comes to you with bleeding. We should have picked it up earlier. We don't most of the time because either we are not aware or the patient was in some other hospital, awareness was poor. By the time they came to us, it was too much. But hypotension developing in a patient, multi-system organ involvement takes place. The patient starts bleeding. Your sister tells, wherever I'm collecting blood, there is leakage from there. These are signs. So it's a clinical diagnosis of DIC. Yes, you can do PT, PTT, fibrinogen, but they are not so specific to pick it up. So again, you can see schistocytes on the smear. Etiology in pregnancy for obstetricians, these are all the heavy duty ones which they never want to face, but these all can cause DIC in the patient. It's all microvascular. The thing is, there is no one diagnostic test for DIC. So it's a clinical awareness on your part on rounds. So you have to say, no, something's wrong, platelets are dropping, there is bleeding from multiple sides, the supports are going up, look at the smear pickup schistocytes. The PT-PDT is unreliable. We already know this, Dr. Kodai just told us, and look at what is the incidence. It could be prolonged and unreliable in so many other patients than DIC. Yes, if the fibrinogen drops, that's very important. If it drops below 100, we know this is DIC, and no doubt about that. The diagnosis of DIC should encompass both clinical and laboratory information. Look at the grade. It's grade 4, a grade C, level 4. That means even they don't know what recommendation to do. It has to be a clinical diagnosis. It can't be any way. Management is, you have to pick up the underlying etiology, give component transfusion, stabilize the patient, and if she is not yet delivered, then you must deliver this patient. Sometimes it's a dead fetus, IUFD, which causes DIC. So please look for that, and then if it is that, we have to deliver the child immediately. Sometimes, not very commonly, we get antiphospholipid antibody. Now what's happening to us, today's world? Many of the autoimmune disorders, these rheumatoid arthritis, post-transplantation, SLEs, they all now have reached an age because of fantastic supportive care and new therapies. They get married and they want to get pregnant. So now we're getting a lot of anemia of chronic diseases coming to us desirous of pregnancy. And they also have thrombocytopenia, they might be on some drugs for it. If you have a patient of SLE, please do look for the antiphospholipid antibody. Because if there is antiphospholipid antibody, the chance of recurrent pregnancy loss in her is very high. So you're looking at a young girl who's finally got pregnant after being, say, 30 years of age, got married, got pregnant, and now she's going to face a recurrent pregnancy loss. So we can give aspirin and LMWH, but my feeling is they should be first counseled about the risk to them before allowing pregnancy. So my second last slide, I think, this is the diagnostic approach to thrombocytopenia in pregnancy. You look at the platelet count. Is there a medical disorder or there's no medical disorder? If medical disorder, go down that line. If there's a medical disorder, look at the history. Is it ITP? Is there any drugs that you can withdraw and see what it is? If it's only low platelets, then you look for gestational disorder, pregnancy, or immune thrombocytopenia. They are the commonest. Or if there is some medical history, some medicine that she has taken in the past or currently going on, withdraw it. However, if the thrombocytopenia is associated with changes of TMA, we are in trouble. So then second trimester, third trimester, and postpartum, these are the differentials that you have to look for, and we'll be able to pick up something in it. This is just to show you that how, as the platelets drop, thrombocytopenia could have different reasons. So we could be having gestational thrombocytopenia. As we go lower in platelet count in the trimesters, the gestational thrombocytopenia, which is in yellow occur, will start reducing. So it's a dynamic thrombocytopenia in pregnancy. It's just not that if she comes with one platelet, okay, it's gestational, forget about it. It might change as time goes along. So here I'm just trying to show you that as pregnancy goes along, platelets will change, it's dynamic, and you may have to keep changing your thoughts. Now in my last slide, I'm going to tell you that what is to be done in terms of delivery. Suppose you have successfully managed the patient, platelets you have managed and everything is going well. More than 80, cesarean section, you can do an epidural, provided the coagulation is normal, I'm assuming here. If it's 50 to 80, you can do a vaginal delivery. If it's 50, most of the time they'll opt for a GA and they'll do a vaginal delivery. But if it's less than 30,000, you need to treat and bring it up, otherwise the risk is higher for bleeding. Between 30 and 50, it's a discussion between you and the patient and what you can do. Maybe you can observe for a little bit more time. Maybe you can start immunoglobulin at this phase, especially if they're close to delivery, and get on with it. So I'm going to end by asking you the questions again. So if you can look at your pad and see what is the commonest reason for thrombocytopenia in pregnancy, the answer is gestational thrombocytopenia. Or what is the hypertensive disorder which is common, hypertensive disorders are common in which trimester? The answer is second to third trimester. Which is the thrombocytopenia associated with thrombotic coagulopathy? The answer is antiphospholipid antibody, because pseudothrombocytopenia does not cause clots, gestational is benign, AFLP actually causes bleeding. And what is the thrombocytopenia, which is the thrombocytopenia associated with the bleeding tendency? Which is the thrombocytopenia associated with bleeding tendency? So the answer is DIC bleeds, HELP bleeds, AFLP bleeds. So answer is all of the above. And how is DIC suspected? The answer is clinically, and I'm hoping you got all right. I would recommend these investigations when you're taking care of your patient. This will cover everything of thrombocytopenia. As your platelets start going below 100, this is your battery of tests. You can call it a gestational thrombocytopenia panel or whatever. A quick reference to pregnancy. Gestational thrombocytopenia, observe. Nutritional anemia associated with treat. Sometimes B12 deficiency causes thrombocytopenia, so please treat it. ITP, observe, but if it goes lower, you can treat. Microangiopathy, everywhere it's deliver, deliver, deliver. No taking panga, no taking chances. Acrothrombocytopenia is benign ethnic. We can wait it out, see the platelet count, and let it go as time goes along. Now, this I'm not going to explain to you. I'm saying that this is a beautiful chart that is there in from one of the British societies as late as 2019. Beautiful, it tells you everything, how to go through each and every problem. And I'm very happy for me to give it to this presentation to Siddesh, and he can give it to whomever he wants, because going through will take 30 minutes any which way. I'll conclude by saying thrombocytopenia in pregnancy has different reasons and outcomes. So assessment, pathophysiology is very necessary. A good history and physical examination usually takes care with a good blood pressure analysis, preferably by you if it's possible, otherwise your senior nurse. Gestation thrombocytopenia is the commonest. Think of ITP if the platelets have started dropping early in the pregnancy or if it's pre-existing. A platelet count of 50,000 is usually taken as adequate for procedures, endoscopy, dental extraction, vaginal delivery, that's all. But epidural, you need 80,000, otherwise they are very scared to do it, provided the coagulation is normal. In ITP and gestation, which is the commonest one, the delivery is as per the obstetric indication, not as per the platelet count. So we'll treat it as per that so that the patient can be taken care by the obstetrician for obstetric guidelines. I don't think we had needed to bring the platelets count of the woman to 150. We need to bring it to safe level. So safe is 80 for a cesarean section. So if we get it to 80, we know that once the delivery is over, probably the platelets are going to rise. So let's not be too aggressive, but let them know, have a good counseling session for them. So safe level is more than a normal level. And like I told you, you can do a gestational thrombocytopenia panel, as I call it, which encompasses a few tests. Look at the whole CBC, please. And look for other cytopenias. Make your pathologist look at the smear, because sometimes you'll miss something else. You'll think of thrombocytopenia, but you need to look at the other things. A rising blood pressure, altered consciousness, rising bilirubin, rising creatinine, patient not looking well, edema feet, proteinuria. These are serious disorders. You need to inpatient the patient, and you need to observe and take drastic steps. So I'll conclude by saying thrombocytopenia may provide a biomarker of a coexisting systemic and gestational disorder, and a potential reason for a maternal intervention or treatment that might pose harm to the fetus. So we have to take care of the mother as also the fetus. That's why we have to be very good in our pathophysiology. Thank you, but don't forget the fetus. Fetus will be born, there might be thrombocytopenia, please take care of the fetus also. Okay, everyone will rush towards the mother, and the fetus might go to the NICU, but in NICU also we need to do the platelet count and take care of the kid, because otherwise her 9 months are going to go to waste. So I thank you very much for your attention.